Welcome to This Explainer. Today, we're taking some foundational cardiology and transforming it into a seriously practical, life-saving tool you can use right on the words. We're looking at a system that strips away all the noise of modern technology and brings us right back to the absolute core of physical diagnosis.
Okay, let's dive into this fascinating fact. In our modern era of high-tech medicine, where we rely so heavily on echoes and complex blood panels, your simple stethoscope is actually still one of the most powerful prognostic tools for an acute myocardial infarction. The way you listen to a patient's chest can literally dictate their survival trajectory. Crazy, right? So what exactly is it? Developed back in 1967 by American physicians Thomas Killip and John T. Kimball, this really elegant classification relies entirely on what you can hear and see to gauge a patient's hemodynamic status. It organizes the severity of heart failure into 4 distinct classes, giving you a rapid, reliable way to assess mortality risk within minutes of a patient hitting the ER door.
All right, here's the quick roadmap for our clinical journey today. We're going to cover the basics of Killip classification, dive in the classes I and II, escalate to classes 3 and 4, talk about the clinical significance and practical rules, and finally wrap up with some clinical examples.
Section 1. Basics of Killip classification. Let's start by looking at the underlying cause of the symptoms we're actually going to be listening for with our stethoscopes.
This brilliantly illustrates the pathophysiology at play. It's basically a domino effect. A blocked coronary artery causes ischemia, which leads to tissue necrosis. And because that heart muscle is dying, the left ventricle's pump starts to fail. As a result, cardiac output plummets, and fluid backs up right into the lungs. That creates the exact physical symptoms, like those wet crackles or rales that we grade in the system.
Moving on to Section 2, classes I and I. Let's see how this builds from a baseline stable patient to early heart failure. So, for Class I, the patient has an uncomplicated heart attack with absolutely no clinical signs of heart failure. When you listen to their lungs, they are completely clear, there's no third heart sound, or S3, and their tissue perfusion is perfectly intact. Based on the original 1967 data, this baseline carries a relatively low mortality risk of around 6%, so generally speaking, these patients have a very solid prognosis.
Now what's really interesting here in Class 2 is the appearance of basal rales and an S3 gallop. This signals mild to moderate heart failure. The fluid is just starting to accumulate right at the bases of the lungs. You might also notice the jugular veins in their neck beginning to distend. And because the left ventricle's contractility is dropping, that fluid backup bumps the mortality risk up significantly, to 17%.
Okay, Section 3, classes 3 and 4. The clinical tension really escalates here as we enter the dangerous territory of severe heart failure and cardiogenic shock.
So, the absolutely crucial point here is distinguishing Class 2 from Class 3. Visually and audibly, this all comes down to whether the wet rales occupy less than or more than 50% of the patient's lungs. If you hear those crackles halfway up the patient's back or even higher, they've crossed a very, very dangerous threshold.
In Class 3, the patient is essentially drowning in acute pulmonary edema. The fluid has totally flooded the alveoli. This patient is likely sitting bolt upright, struggling for air, bringing up frothy sputum, and experiencing this really intense feeling of fear. This is severe heart failure requiring immediate high-flow oxygen or non-invasive ventilation. Why? Because the mortality rate approaches an alarming 38%.
Finally, we reach Class 4, cardiogenic shock. Here, a massive portion of the myocardium has died. The heart's pump function has completely collapsed, and peripheral circulation just comes to a grinding halt. You'll see extreme physical signs of hypoperfusion. The patient will be covered in a cold, clammy sweat, their lips and fingers will turn blue with cyanosis, and that lack of blood flow to the brain, that's going to cause confusion or altered consciousness.
And here's the defining hemodynamic metric you must instantly recognize for Class 4, a systolic blood pressure plummeting below 90 millimeters of mercury. This severe arterial hypotension is the absolute hallmark of cardiogenic shock. Seeing the mortality rate aggressively spike up to between 81 and 90% for Class 4 visually hammers home exactly why early and accurate classification is truly a matter of life and death. The prognosis literally drops off a cliff the moment the patient enters cardiogenic shock. Section 4, Clinical Significance and Practical Rules. Now that we know the 4 classes, why does this actually matter for your rapid clinical assessments on the floor? Well, beyond just giving a prognosis, your bedside Killip assessment directly dictates whether the patient needs standard care or immediate ICU resuscitation and mechanical support. It's so incredibly reliable that it remains heavily weighted in modern predictive models like the GRACE and TIMI risk scores. It guides aggressive treatment tactics, like initiating inotropes or vasopressors in Class 4. Plus, its universal simplicity means you can use it anywhere in the world, instantly. No fancy machines required.
Section 5. Clinical Examples. Let's step into the clinic with some real-world interactive cases to tie this all together.
Okay, picture this. A 67-year-old patient presents with dyspnea, basal rales, and an S3 heart sound. Based on those basal rales and the S3 gallop without full pulmonary edema, how would you classify this patient using only your stethoscope? Take a quick second to lock in your answer.
If you deduced Class 2, you are absolutely correct. This presentation means the patient has mild to moderate heart failure and requires oxygen if their saturation drops, alongside diuretics like furosemide and vasodilators to manage that early fluid buildup.
Now for our final clinical mystery. Consider a 69-year-old patient with extreme hypotension, a systolic BP of 70, oliguria, a cold sweat, and confusion. What is your rapid assessment here?
This classic presentation of cardiogenic shock places the patient squarely in Class 4. This demands immediate vasopressors, intensive care, and potentially emergency mechanical support. Every single second counts when blood pressure drops to these levels.
But here's a crucial takeaway. The Killip class is not static. An effective physician doesn't just assess the patient once. They use these clinical skills continuously to monitor how the heart responds to treatment over time. A patient might present in Class 3, but with rapid intervention, diuresis, and reperfusion therapy, you can literally watch their classification and their chances of survival improve right before your eyes.
So, next time you're on the ward, will you rely solely on waiting for the lab results, or will you use your own eyes and ears to predict the trajectory of a heart attack? Mastering the Killip classification empowers you to make critical decisions when seconds matter most. Thanks for joining me on this explainer, and keep honing those clinical skills.